Good afternoon. We're going to start our afternoon session. Our first speaker is Dr. Joseph Zayac, who will talk with us about the aging eye and problems that we experience as we age. Thank you.
Thank you. Good afternoon. It's a pleasure being with you this afternoon. My name is Joe Zayac. I'm an optometrist and I practice clinical optometry for the Department of Ophthalmology here at the Health Science Center. My background is I've been here about 6 years. Before that I was a military optometrist for 22 years, so that's where I'm coming from. My format, if we could get the first slide up there, please. I'm going to start from the anterior of the eye and move back and discuss some of the different things that go on with aging. We'll start with the cornea, then as we go through the next chamber, that's the aqueous humor, which is a clear fluid. Then you see the iris. The black spot in the iris is the pupil. We go through the lens of the eye. The biggest cavity of the eye is the vitreous humor, which is a gel. Then we'll get to the retina and the optic nerve. Now the lecture today is geared towards the aging eye. As a non-ophthalmologist, I feel that many of the patients that present to you present to me in the same way, so hopefully this will be a benefit to you. Now, although most of this is about aging, many of these conditions also are in the small ages and all through the ages up to the geriatric stage. As you can tell by this little girl's spectacles, which are very thick, she is aphakic, which means that she has had cataracts removed, and so she fortunately does not have to wear the thick glasses like that. I fit her with contact lenses when she was 1 month old, so she wears those and she does very well. But cataracts are common with aging, but they are also present at different ages. Now, anytime you examine the eyes, you need to get some type of visual acuity from a medical and from a legal standpoint. And visual acuity is the benchmark of the way we determine how the eye is progressing through age. The top number, the numerator, is the distance at which the patient reads the chart, and that's usually 20 feet. The denominator is the distance at which someone with normal vision reads the chart. And so typically you hear the 20/20 vision. Now, as an example, if someone has 2300 vision, that means that the person that has 20/20 vision can stand back 300 feet and see the same thing that someone that has 2300 has to stand up 20 feet to do that. Now, in some situations, people cannot even see the big E on the chart, which is 2400. So then you have the patient walk towards the eye chart until they can identify that large letter. And so in a case like this, the visual acuity may read 10/400, and that's a visual acuity. And some people can't read letters at all, the next designation is count fingers. How many fingers am I holding up, and record the distance that they are seeing those fingers. If they can't count your fingers, can they see your hand movement? That's hand motion. The next thing is, can you perceive light? So holding a pin light up and seeing if they can perceive the light. And then, of course, there's no light perception. Now back to the slide, visual acuity is considered to be legally blind when a person cannot see with their best corrected vision of 2200. So many of the patients will say, well, I'm legally blind, but they're not legally blind. They may have 2200 vision, but it's correctable to 20/20. So this is when it's uncorrected. Also, a patient can have better than 2200 and be legally blind for the government standpoint if they have a small field of vision. If the peripheral vision is not there, they can, down to 20 degrees is considered legally blind. To drive in Texas, you must have 20/40 vision. Now, the most common complaint that, as you would imagine for a eye clinic or for anyone about their eyes, is blurred vision. Now, a lot of times you're in situations where you cannot refract the eye, and what that means is where you use lenses to see if that improves vision. And we're in that situation many times too, where we don't want to spend time doing a refraction or checking the patient's vision. So we use this little device here. And over the patient's right eye it's occluded, it's just black, but in front of her left eye that has a little series of pinholes. And so if the patient puts this up, and in this case looking through her left eye, and sees better on the eye chart, we know that the vision loss is due to a refractive error or a need for glasses. And so we can stop there. We don't know what the prescription is, but we can stop there and continue. You can do this same thing by just taking a 3x5 card and push a couple of little holes in it, have them hold their hand over one eye and hold this over the other. And if their vision improves, they probably need glasses to help their vision. Now, the reason this works is that in all situations, the light that comes right through the center of our eyes is unrefracted, so even though you're terribly nearsighted or farsighted, you still see that ray of light unrefracted, and so that's how the pinhole effect works. Now, in the back of some of these journals, you'll see pinhole glasses improve your vision, that sort of thing. That's just really a gimmick. You actually do see from that, but your field of vision is so limited that it's not practical. Now, what we use in optometry and ophthalmology to describe a prescription is called the diopter. The diopter is the inverse of the focal length of the lens, or the refraction in meters. You'll see prescriptions written with a plus or minus sign, and then usually three numbers followed by it. But let's talk about the individual types of refractive errors and how they affect with aging. Now, myopia or nearsightedness, light falls in front of the retina. And so it essentially means the eye is too powerful, either because the cornea is curved too much or the eye is too long. In most cases, it's a combination of both. This is corrected with a diverging lens, or we designate that with a minus on the prescription. It can be corrected with glasses, contact lenses, or now refractive surgery. It is the most common refractive error, and that's what keeps my paycheck coming in, fortunately, so we do see a lot of that. The patients complain of blurred distance vision, and they do see very well up close. As a person gets older, they become less myopic. There's a tendency to become farsighted with age. And so older patients who are wearing older glasses have trouble reading even though they're nearsighted because they're overcorrected and they can't accommodate for that. So they'll often take off their glasses to read or do something like this. Cataracts also make you become more myopic. So that's an indication. As a matter of fact, a lot of the patients will say that they're getting their second sight back, as they call it. And it's just that their cataracts have developed so much that they're nearsighted now, and so they can see up here. But if you ask them how they see far away, they can't see. So that's myopia. Now, if we could switch to this slide, this is right across the hall for me. This is hyperbaric medicine. And many of our patients, especially our diabetic patients, are referred to this facility, or a similar facility, for hyperoxygenation. And this hyperoxygenation, in many of these cases, makes them myopic. Sometimes the largest shift is from 20/20 to 2400, so they can be big shifts. So if there's a sudden shift, and if it's not related to the diabetes and they've had this kind of a treatment, it's good to get a little history about how they do, if they've been through one of these chambers recently.
Does the myopia correct itself?
It will, yes, yes. Now, hyperopia, typically the eye is too short, so the light falls behind the retina. We correct this with a converging lens, or a plus lens it's called. With age, the patient gets more hyperopic or more farsighted. Now, in the early stages, in the younger ages, if you're farsighted, you can see pretty well both at distance and near because you can accommodate for that. As you get older, you lose more of that, and your distance vision and your near vision are blurry. So that's how hyperopia works. Now, also, you have to be a little bit suspicious if a patient complains of a hyperopic type complaint. Tumors inside of the eye, edema, elevations of the retina also mimic this hyperopia. So it's cautious, it's important to be cautious there. Now, astigmatism is common. And astigmatism simply means that the two principal meridians, which are 90 degrees apart, do not have the same curvature. And the difference between them is astigmatism. The typical analogy is like the football versus the basketball. The basketball would not have astigmatism. The football has an astigmatism. And most people understand that. Again, this is corrected with lenses. These are called cylinder lenses, so only part of the lens corrects and the rest of it balances out with the nearsightedness or farsightedness correction. You're now able to correct for this in refractive surgeries, which is fairly new. Astigmatism doesn't change with age. It pretty much stays consistent. Now, this is the most common thing that the aging complain about. It's called presbyopia. This is due to the inability to accommodate for things up close. When the patient looks at something, this little lens, the crystalline lens inside the eye, no longer has the flexibility with age to focus on things up close. So the typical patient will say, my arms are getting too short. I have to hold everything out here to read. So this is presbyopia, and the common refractive condition that happens with age. And again, as I mentioned, myopic patients, because of presbyopia, will take off their glasses and hold it at the focal length of their eyes. Now, in addition to spectacles, a lot of older patients are wearing contact lenses now, and that's because of these soft lenses, which are so comfortable. Now, this happens to be a hard lens in the middle there, and I put this up for dimensions. The part that's sort of magnified there is a rigid gas permeable lens, and that's 9 millimeters to give you some idea. Most people think of the eye as big, but the eyes are actually quite small, about 1 inch long. Now, if you look very closely, I don't know if you'll be able to see here, but on the outside, on the sclera of the eye, there's also a soft lens. So the hard lens is on top of the soft lens, and this happens to be my eye. I have a condition where, with age, my eye is becoming pointed or keratoconus, so I have an ectasia of my cornea. So for me to have good vision, I actually wear 3 lenses. I wear spectacle lenses and 2 contact lenses to get by. And you'll see patients like this, and so if they tell you that, they're not crazy, they're doing that. But as the eye becomes pointed, the soft lens is there as a comfort factor, and the hard lens is what is doing the refracting. But many patients nowadays are wearing contact lenses. One of the most popular methods is to wear a contact lens for distance vision in one eye and one for near in the other eye, and not have to use spectacles. Now, this is a picture of a person that's had refractive surgery. Refractive surgery is very popular now. You read about it in the newspaper, or you hear ads on the TV. This particular patient came to us from a center that she moved to San Antonio and was treated in the West Coast. Now, those radial marks that you see, those are radial keratometry. Those were done about 15 years ago or so, where the surgeon actually made an incision about 90% through the cornea. Typically, you make about 4 incisions, and the idea is that it flattened the cornea and corrected the myopia. In her case, that didn't, so they kept cutting, and they made more. She also developed astigmatism, so they made little arc cuts along there too. That didn't work so well. Then so the laser came out with a LASIK. The annular ring that you see there is a LASIK cut. And unfortunately, I think by that time the eye was so distorted that that didn't work either. And her vision when she came to us was about 2200. So we did a corneal transplant. Our surgeons here did a corneal transplant on her. And I saw her about a month ago and fit her with a contact lens. Unfortunately, she's down to 20/25, but that's because she has a new cornea. But refractive surgery, I didn't want to scare anyone, is very safe. And it usually works out very well. And the newest procedure is this LASIK, which is a reshaping of the eye. They can do it for hyperopia, where they remove tissue from the outside part of the eye, or myopia on the inside, and they also correct for astigmatism.
It's not much good on presbyopia, though, right?
That's correct. That's an excellent point. It does not correct for presbyopia, and we tell all of our patients it won't, but somehow, because the way that laser cuts, since the eye is not spherical, many of them are out there reading the newspaper, and it frightens us a little bit because we think their vision is blurred far away, but they actually do see 20/20. But you're right, that does not correct for presbyopia, is what we tell patients. I think in the future they will develop a technology where they can actually curve the cornea to where a patient will be able to read.
Correct me if I'm wrong, but I have been reading articles because I was thinking of having that myself, and the more I read, the scarier I get. Because I'm dealing with my eyes, because I've read articles where they say somehow as you cut with a laser, it doesn't heal back right the way it's supposed to. And then your side effects are the big halos and all this.
Yeah, you'll hear a lot of stories, and if you really want to be scared, get on the internet. Okay, so people have actually descriptions of problems that they've had, but for the most part that doesn't happen. That's very good. But what more happens with these halos is that the ablation zone is about 8 millimeters, and many people's pupils at night are 6, 7, 8 millimeters. So the entire cornea is not ablated. So when your pupil is near that area, you do get these halos and that effect. But you should be cautious about that. If your eyes are darker, it's usually not a problem. And if you've had an experienced surgeon, it's usually pretty effective.
Or if your pupils are bigger than normal, right?
Then you're more likely to have those halos. And you might want to consider, or you might want to wait. Although now they do have these little microtomes that do make bigger ablation areas. But it's a common problem. It's a common problem even with hard contact lenses, but many people adjust to it. But if you're used to sharp 20/15 vision with glasses, you may be disappointed. Another problem is that a lot of times the eye, after it has been lasered, ends up too flat. In other words, the eye was not steep enough, and so the eye was long, which created the myopia. And nature has given us a pretty good shape that that we have adjusted to the refraction for the cornea. And if it ends up too flat, then again you have these distortions. You may not need glasses, but you may not have 20/20 vision. So there are some considerations. But when you go in nowadays, most surgeons are pretty experienced. They'll know all of this before they would do the surgery. Now if we go to the next slide. When I examine a patient, a lot of times I'm forced just to go right to the eye and just look at that. But I like to sit back and kind of look at the patient as a whole. In this patient, you can see that there's some wrinkles in his forehead, so he's doing that to try to hold up his eyelids. He has a little rosacea. You can tell that if you look at the pupil reflex, it doesn't look like the eyes are lined up. There's a little difference in the pupil from one side. There's a little cancer lesion site on there. So come back and just look at your patient from 2 or 3 feet away before you just focus on just one area. Now in ophthalmology, in optometry, we have just wonderful equipment. It's very sophisticated, but one of the best things is just the basic pen light. You can illuminate the eyes and see better. You can check the pupils to see how they react. You can judge the anterior chamber, how deep it is by showing the light from the side of the eye and look at the reflection on the other side. And you can also use it to check the binocularity of the patient. So a pen light is a valuable instrument. Now let's begin with the lids. The lids serve a very important function. They protect the eye from foreign bodies. They create the oils that mix with the tears to protect the eye, and they swoosh the tear across the eye. Now these are two common things that you see. On your left is a stye, or a hordeolum. Now there are vertical glands called meibomian glands that secrete oils that lubricate the tears in the eyes. And when one of these little glands becomes blocked up, it just backs up. So these are usually tender, a little bit hot, and the immediate thing you should have your patient do is apply hot compresses. So run hot water over a washcloth and hold it on there for 3 or 4 minutes. And then massage. If it's the upper lid, you massage from the top down. From the bottom lid, you massage up, and to get that to drain. Now still, some of them don't drain, and so you get that lesion on the other side, which is called a chalazion. The material in there has just hardened. It's no longer painful. It leaves this little bump, and most people, it doesn't bother too much, but some of them are quite large. And I've seen them so large that they actually indent the cornea and cause them to have blurred vision. Now, if it's real cosmetically unsightly, they can be surgically removed, but usually with time they'll go away also. Now, the plastic surgeon, the ocular plastic surgeon that I work with, says if a person gets recurrent chalazions, you should always maybe consider referral to an ophthalmologist so they can biopsy them for sebaceous cell carcinoma. So be aware of that as well. Now this mimics a hordeolum or a sty, but this is dacryocystitis. This is inflammation inside the tear drain system on the side of his nose there. And so if this gets too inflamed, it can scar the lacrimal system. And the lacrimal system goes back through the nose and back through the throat. So this needs to be referred and treated and with antibiotics. Sometimes they actually need to run a little wire through the system to clear this out. And systemic antibiotics are required in this situation.
And that's called what?
Dacryocystitis. Dacryo meaning the D. Mm-hmm. Yeah. Now, this is a common condition that you see in almost all people. If you look at the lashes, there's these little crusts and kind of oils there. We call this blepharitis. It's just inflammation of the eyelids. And a lot of the older people have it because they just have lost their ability to clean hygiene well. And what we recommend for these patients, besides like a topical antibiotic ointment, is baby shampoo on a washcloth just to scrub the eyelashes. And a lot of people are afraid to get close to their eyes, and especially with soap, so if you get the baby shampoo, it doesn't sting. But those need to be cleaned off, but very, very common in the geriatric population. Now this lesion looks like another sty, but this is a basal cell carcinoma. So that needs to be referred and excised. And fairly common, especially in the Sunbelt area. Now this is with the lid pulled down, looking at the little, looks like a little freckle in there. This is a very serious condition. This is malignant melanoma. So this particular patient, this lesion has been removed, but it did reoccur. And unfortunately, the next option they're giving her is to remove her eye and the contents of her orbit. So it is unusual to have pigment in this area of the eye. So just pulling down the lid, and often when you examine the eyes, you do not do that. You just kind of look at the wide of the eye, the cornea. So pull down the lid and look into what's called the fornix there. If you see pigment, refer it.
And what we're looking for is that little heart-shaped dark spot.
Yes. That should be normally clear through there. Now this is an awful looking picture, but this is caused by us. She came in because she had conjunctivitis or pink eye, and we gave her neomycin, and she's allergic to the neomycin, so the neomycin is much worse. You know, the treatment was much worse than the condition that she came in for, and so this needs to be appropriately treated. We seldom use neomycin in optometry or ophthalmology because many people are allergic to it. But Neosporin is your common ointment that has neomycin, so we very seldom prescribe that for this exact situation. Now, this patient has a thyroid disease, a Graves' disease, and so you'll get in this case, a bilateral pushing forward of the eyes, which is called exophthalmos. initially, if the condition is not too bad, they usually just complain of dryness because their eyelids do not close well, especially when they sleep. You have to lubricate them and put ointments in front of their onto their eyes to protect their eyes. Now, in advanced cases, though, this can affect the optic nerve. It can cause ophthalmoplegia, where they can't move the eye, and compression and ischemia of the retina, so it can be very serious. If you see only one eye pushing forward, that needs to be referred also, because that can mean that there is a tumor or something behind one eye. Now, let's talk a little bit about the eyelid and the tear film here. The most common problem that we see is dry eye. And as the patients get older, their eyes get drier and drier. And as I mentioned earlier, the lids of these different glands that are reflected in the slide there are what produce the oils. The lacrimal gland produces the tears. And when that dries out, the surface of the eye becomes irritated. And so you have these complaints of foreign body, burning, irritation like this. And paradoxically, they'll complain that their eyes water all the time. And that's just a reflex tear because the eye is so dry that it's trying to wet itself. So if a patient comes to you with a lot of tears or complaining of that complaint, their eyes are dry. So what you can do is prescribe artificial tears over the counter. They have lubricating ointments that they apply. And also, right in the little corners of the upper and lower eyelids, you can actually insert a little plug and block up the tear drainage so the tears block up and form a little dam there, and it works very, very well. Now this is kind of what a dry eye looks like. You almost can feel for this person. You know, there's just no moisture in there, and in the lower area there, that'll scar. And then so it pulls the lid out, and so now they don't have that lake of tears in there, and so these are extremely uncomfortable people. Hopefully they get some relief from lubricating drops, and in a case like this would almost need ocular plastic surgery to make this patient more comfortable.
So when you see elderly that have the real reddened lower eyelids that, like you said, seem to turn out, that's just basically scarring from having a very dry eye.
That's exactly right. Plus they lose laxity of the eyelid, so it just hangs out, and so there's not that complete flow across the eye to lubricate the eye, so one leads to another. So those patients, now some of them, the reverse will happen. The lid will actually turn in, and then their eyelashes will scrape their eyes. And if you get a good magnifier and tweezers, you can pull those little things out, because you'll make them so much more comfortable. Some of our patients come in about once a month and just plop down on your seat, pull these out, don't even make appointments. But you can do that because it is very uncomfortable when the cornea dries out. The cornea has to have a clear tear film to be comfortable.
Does a dry eye contribute to blepharitis at all?
It probably does a little bit, but it seems like to be just a triad of these kind of conditions. You're exactly right. Now, let's move on to the conjunctiva. The conjunctiva is a clear membrane that's attached to the eye, makes a little loop, and then comes back and attaches to the lid. It's clear, but it does have have blood vessels through it. The part that attaches to the lid is called the palpebral conjunctiva. That attached to the eyeball itself is the bulbar conjunctiva. Now this is always a gross photograph, but this is passed around in some of the textbooks. You usually don't see it like this, and you almost wish you did, because it would be pretty easy to diagnose. When you see these purulent, yellowish type discharges, that's just bacterial conjunctivitis. But bacterial conjunctivitis by itself is fairly rare. The hallmark there, though, is the purulent discharge for bacterial conjunctivitis, and that is treated with antibiotic drops. But most of the eyes, you really don't know if it's what kind of conjunctivitis they have. So again, get in the habit of pulling down the lower lid. And one way that we tell is we have magnifying loupes, but many of these little lesions you can see just by pulling down the lid and using your pen light. These are follicles, so they're just little lymph sacs in there, and these are common with viral conjunctivitis, which most conjunctivitises are. They're just sort of self-limiting. Antibiotics have no effect on it, and so you just want to make the patient comfortable. We usually do prescribe an antibiotic, but it's probably or probably shouldn't. Also with this, you will get the preauricular swelling, and these are usually fairly contagious. Instruct the patients not to share washcloths with other family members and replace washcloths, that sort of thing. Wash your hands frequently. But this is viral conjunctivitis, the most common. Now, allergic conjunctivitis is real common here. And again, this looks kind of gross, but it's not. It's just the eyelid has just been flipped over, and you always had some kid in school that could do that and walk around like that. The eye can look pretty white if you just look at that, and gosh, it doesn't look good. But the guy is complaining about itching and a little bit of tearing, and if you flip the eyelid over like that, you'll see these papillae, and they look a little bit different from the follicles, and these usually respond very well to like mast cell inhibitors or antihistamines, some of them over the counter, but they do have some very good prescription drugs that work very well. In this area, the cedar fever is, especially this time of year, is starting to go away now, but many of these new antihistamine combination mast cell inhibitors work very well for the patients. Now this is a contact lens patient. Again, this is where the lid is just flipped over. And if patients don't clean their lenses regularly or don't replace them regularly, they'll get an allergic reaction on the inside of the lid, because that is the part of the lid that is moving across the dirty contact lens. So we call this giant papillary conjunctivitis. The papillae are a little bit bigger. And you'll see it on about anybody that wears contact lenses, but you'll see it a little bit more on patients who don't take care of them very well. With the advent of the disposable lens, the one-day lens, this is a good answer to patients that don't take good care of their contact lenses. Now this also looks like a conjunctivitis. You see the eyes are a lot of injection there. But if you look closely on the temporal part, or the inflammation is more congested by the iris there and by the cornea. So this patient, okay, this patient has iritis. This is an inflammation inside of the eye, of the uvea tract of the iris, and this is serious, and this needs to be referred. But if you would just look at that, you'd say, well, let's just give this patient an antibiotic, drop, and send them on their way. Usually the patients are a little sensitive to light or photophobic, and also the pupil is smaller than the other one. So look for this. Most of the times they're quite uncomfortable, but many times patients like this are treated with for conjunctivitis when they have iritis. And topical steroid eye drops work very well with this, but there's many times underlying conditions of the iritis that need to be investigated. Now let's move on to the white of the eye, the sclera. On your left slide there, that's a scleritis, an episcleritis. And often it's associated with rheumatoid arthritis. These are treated very well with topical steroids and usually go away. They're usually very painful for the patients. And so they're different than a conjunctivitis. This is a scleritis. Now, unfortunately, the picture on the right is a very advanced scleritis, and the patient will lose the eye in this case. Now, you've all seen these. This is a pterygium, and they're caused by sunlight. And so the tissue is just irritated by the ultraviolet radiation and starts to grow across the cornea. 15 years ago in our practice, they would remove these immediately. But nowadays, they don't do much with them unless the patient really complained about a cosmetic effect, or they're approaching the pupil and they're starting to interfere with vision. Because once they remove them, often they regrow. And if they're removed too many times, the cornea gets thin and creates an irregular astigmatism, so it starts to affect vision. This one we would probably just leave alone, but if it goes on too much farther, it's going to create a lot of astigmatism, and the patient will get astigmatism, blurred vision from the astigmatism, and the lesion will have to be removed. A lot of the times the lesion doesn't advance to the cornea, but patients will see this little brown spot on the brownish yellow spot on the white of the eye and get concerned about that, and that's a pinguicula, and that's just a pre-stage of this, and they usually don't advance. And so you just tell the patient to leave it alone, not to pick with it or try to treat it. Now let's move on to the cornea. This is a corneal ulcer. And you see that little layering of white down at the bottom there? That's in the aqueous humor. Those are white blood cells. And that's called hypopia. And so corneal ulcers are very serious, and they're treated. They need to be referred immediately, and they need to be treated with fortified antibiotics around the clock. Now, in most cases, they heal pretty well, but even though they heal, they leave a scar. So often these patients have to have a corneal transplant, especially this patient, because the scar is going to be right in the middle of the visual axis. Now, this is one reason patients get corneal ulcers. Okay, this is actually a patient's contact lens case. He had it in his pocket. I took it away. It was just filthy. And I said, you know, those things are about 50 cents. You know, buy one or wash it at least. And so, especially with contact lens patients, if a patient has any kind of a corneal irritation, refer them. A lot of times, the corneal irritation or the corneal ulcer is because of Pseudomonas, and that can destroy the cornea in 24 hours. So it needs to be referred immediately. So if they're a contact lens wearer and they've got a corneal problem, get rid of them that same day. Now this slide shows a corneal ulcer, but this is associated with rheumatoid arthritis. And so the cornea has just thinned, and that yellowish area in the bottom is where the ulcer is, and that's just fluorescein dye that we've put in there to make it show out better. And these can perforate. So look at, especially with your arthritis patients, very, very closely. You see this fairly commonly. This is herpes zoster, and it follows a trigeminal. You get these little vesicles, they'll follow down. Now if it goes all the way down to the tip of the nose and has a lesion right on the very tip, more than likely the eye is involved. And so that's a clue. They call that a Hutchinson sign. But it doesn't have to go there, and you can still have the eye involved. And so that's what the picture is on the left-hand side there. You don't see that too well, but the cornea is accepting the fluorescein dye. And this is one case that steroids are used, but very cautiously, and they're usually combined with an antibiotic. On the other hand, this is herpes simplex of the cornea. And if you use steroids here, it's like putting gasoline on a fire. So be cautious if you use these combination antibiotic steroid drops, because if a patient has herpes simplex, you'll be in a world of trouble.
And herpes simplex is your cold sore.
That's right.
Mm-hmm. So you're almost, if you were going to get treatment for something that you're calling a doctor for, you're almost going to have to get that person in to see.
If you suspect the eye.
Yes.
Yes. We have to look at those, because those are, although you could maybe hold up the little ultraviolet light, you can see these, but those need to be referred. Now they respond very well to, they do have antiviral ointments and drops that typically respond. But again, another problem is that they scar. And then a second problem is that they reoccur. Now, this is a dystrophy of the cornea, which happens in older age. and they're fairly common. There's all different types, and they're named after famous doctors and professors who've isolated, depending on their size and their shape and different levels in the cornea. This one you could just see with a pen light. Some of them have to be seen with the biomicroscope, but very common, and these do affect vision. Now this is an interesting one that's fairly common. It's called Fuchs Dystrophy, and when you look at the eye, it looks a little cloudy. And it looks like the surface of an orange peel, and you can get that effect. And the patients like this wake up and their vision is cloudy. Everything looks like they have just gotten out of a swimming pool with that effect. You've had that. And it's because the endothelium, the inside layer of the cornea, is not pumping, the fluid is not operating properly. And initially, we have the patients take a hairdryer and blow their eye. Try to dry this to give them a little bit of vision. The lubricating drops may make them a little more comfortable, but a lot of times these break down and they get these very painful bulli, and they're very uncomfortable and fairly common. And one thing we do is put a soft contact lens on as a Band-Aid to help these patients.
And it occurs overnight? I mean,
Well, it's a long occurring process, but that's why the patients will complain. Initially, the patient may come to you and have an episode, and you start to see these little things, and you may mention, well, I think you're going to have a corneal dystrophy as you get older. And then they'll come to you, sure enough, with I got cloudy. A lot of my patients are contact lens wearers, so they think it's the contact lens, but if we take the contact lens out, they still have the corneal edema, and so it's a problem. But can be very uncomfortable for patients. Now we'll go to the next slide here. This is a corneal transplant 2 days after surgery. And it's a remarkable operation. These do very well. The graft holds in about 95% of the time. They do well. And you can see, I think if I magnify that a little bit, do you see the sutures there? Remember that the cornea is about 3 or 4 thicknesses of paper, so that's pretty fine surgery. Actually, the suture material to do those is so light, if you let go of it, it will fly in the air. But it's a remarkable operation, as I said, that they do very well. Your patients need to be told, though, that the time for using the eye or the recovery is, can sometimes be a year. What they will do is, since even though it looks like extremely fine surgery, it creates astigmatism where those sutures are. And so we have instruments that will measure the shape of the eye, and where one is pulling too tight, they'll cut that suture, give it a few, maybe a month, and see where it is, and try to get the eye as round as possible. But most of them, even after having that done and all the sutures are removed, still require most cases a contact lens, a hard contact lens to smooth out the regular astigmatism, or glasses. But I have seen some that have very good vision even without any kind of correction. Also, in some of these cases, some of the sutures are left in there permanently, so if you see a suture in there. And those that have been there a long time may work themselves forward and cause irritation, and so those need to be referred for removal. Now let's move to the pupil. The pupil is the black spot of the eye. This is Horner syndrome, where you have an unequal pupil size, and you have a ptosis, which means that the lid, in this case, it's the patient's left eye there, is lower, so that's a ptosis. The pupil on that side is miotic, it's smaller, and they don't sweat on that side. So if you have them run up and down the stairs, they'll come with a red face here, and they'll be clear over here. Also, there's a tendency for the eye to be a little bit farther back. Now, if this is an acquired Horner syndrome, those need to be referred, because there's an eruption in the sympathetic pathway somehow, which could be from a tumor or something like that, so those need to be referred. Many people have them congenital, and those really just more of a curiosity than anything. In the congenital ones, there will be a heterochromia, which means that the irises are different color. The affected eye is usually the lighter colored one. But when you look at with the pupil at your at your patients with the pupil. Also judge the size of it relative to each other. Now, this is a surgical pupil. This patient has just had a cataract removed years ago, and the pupil looks like it's displaced, and they couldn't see through that. That's 20/20 vision. So there's no problem with that. And what happens here is the eye is being held up a little bit, the eyelid, and so when that lid comes down, it makes its own pupil. And so that's not really a problem, but it's kind of a neat picture. Now, let's move to the Crystalline Lens. Right next to me also is the cardiac catheterization laboratory. And the chief of that told me that their doctors, technicians, nurses get more radiation than anybody in the hospital. And I routinely see them wearing all the leaded aprons and gear around their neck, but a lot of them are not wearing glasses. And they will get cataracts. They do make leaded glasses for this, and the chief makes sure that he always wears them because radiation induces cataracts, and especially in this, and fluoroscopy or other areas where you might be, you should wear leaded eyeglasses. Now this is a immature cataract. We all develop cataracts as we get older. The crystalline lens is normally clear and just clouds with age. This one is what they would call pre-surgical, and they usually operate on them when the patient can no longer see about 20/60 vision. Sometimes sooner if they're complaining about glare, and in this case, we'll sometimes dilate the pupil so it looks around the cataract and gets a little bit of light in there. Now this is a mature cataract, and you can see this with just your pen light, and this one needs to be removed. It would, pretty easy to see, and you can almost see them with just normal light when you see this in patients that come in. Now, many of your older patients are frightened when you tell them that they have cataracts, because in their generation, when they had a cataract, after the cataract was removed, the entire lens was removed, including the capsule, through a large incision through the top of the eye. They had to stay in the hospital for 2 weeks. They had sandbags put around their head, and so they're very frightening. Nowadays, our surgeons here in about 15 minutes remove it on an outpatient basis. And the way they do it, they make a little small incision, usually on the temporal side. The little intraocular lens, which this depicts here, is folded. And after they've removed the cataract, they take the cloudy part of the lens out, but they leave the little capsule inside. And then they insert this little lens in there, and it flips open, and those little wires on each side are flexible, and so they can turn that and align it, and then it'll just pop out in its size. And then the prescription is adjusted based on the length of the eye and how curved the eye is, so they don't need glasses, but again, they're still artificially presbyopic because you can't correct both distances, although now they are starting to do this, and this particular lens has a bifocal in it. So you have that. It has to be centered very well, but this is that. Now, a lot of people think that, have the idea that cataracts are removed by lasers, and I don't know where that comes from, but you'll see that this is YAG tolerant. What happens in maybe 20% of the cases, after they've had cataract surgery, the little capsule that is holding the lens becomes opaque. And it's like a secondary cataract, although it's just opaque like that. Then they will use a YAG laser right in the office and just open that up, and it doesn't have to be done more than once. So if your patients had a cataract surgery 6 months ago and they notice their vision is getting cloudy again, refer them in, even though they've been dismissed by their surgeon, and let them look at the capsule because it can be lasered and will restore the vision again. Now this is the eye of that gentleman that I showed you, the full face. And he was involved in a motor vehicle accident, tore the iris. So you see where the iris is missing. And if you look carefully, I don't know if you can see it that well, you can see the interocular lens in there. So he was aphakic, and so he had a pseudophakic, and he has the little blue haptic. He also had a retinal detachment, but all of these things didn't bother him as much as being sensitive to light. Because with this big pupil that doesn't constrict, he was terribly photophobic and just came in almost holding his hand over his eye. So this is what I did. I got a hand-painted contact lens and with a fixed iris, a pupil, and colored the iris to look pretty close to his other eye. It looks pretty close, I would think. You can still tell that the eye's a little bit red from the retinal detachment surgery, but this made him very comfortable. And if you get these patients now that have disfigured eyes, or especially even the children, it's difficult to go around with a disfigured eye or a white eye. Refer them to us, and we can. It's much easier now. These are soft contact lenses. We can specially color them and put in pupils and match their eyes pretty well. So keep that in mind. This is an interesting photograph. This is the pupil, and then through the pupil you'll see these little membrane type fibers there. This is a lens, crystalline lens. It's just dislocated, it's fallen. It's normally held right exactly in the visual axis, but it's fallen. This patient has Marfan syndrome, and those zonules that hold that get lax, and the lens drops out of the way. Now, we almost hope that it drops all the way out, and that way you can just correct the prescription straight through it because it's clear and now essentially aphakic. But a lot of times they'll bisect the pupil like this, and so this creates a large amount of astigmatism, and the patients don't see too well. It's hard to do this. And plus, some of them you can look at them and ask them to move their eye, and that lens will bounce up and down, and you'll see it. So they're very uncomfortable.
But there's no way to go in there and reattach that lens? Or
No, they'll remove it if it's easier to take it out, and that's the case. And this individual has since had that removed. Now, y'all may have had a chance to use the ophthalmoscope. Our medical students here have a heck of a time with it. So it's a nice instrument, but it takes practice to use it. Now, typically when they'll come to me, they'll have the light all the way turned up in a big aperture, and I ask them to show me, well, how close do you get? And they do all things wrong. You need to just barely turn the ophthalmoscope on. You just need very dim light. You need to put the smallest aperture on, and you need to get right up into the pupil, right up into that pupil, so that actually the patient's eyelid is brushing against your ophthalmoscope. Then you know you're at the right distance. Getting that close also helps you stabilize it so you're not so shaky moving around. Also, if you'll notice in there, there's little numbers in there. That is the patient's refractive error. So that tells their prescription. Pretty close, not astigmatism, but it's pretty close. And so if you're looking at a patient and you see in the red numbers will be minus or diverging lenses, that means they're myopic, and if they're not wearing glasses, you need to ask a little bit of history about that. Especially kids, if you're doing children in a screening, ask about that and check their vision on an eye chart. On the other end of it will be green numbers or black numbers, and that indicates farsightedness. Now these are the people that really need to be watched, especially the younger ones, because they can be sometimes 6, 7, 8, 9 diopters hyperopic and still see 20/20 on the eye charts. That's why the school screenings are not too good for hyperopic children. So if you see that, refer the patient, because these are the patients that have difficulty reading, may have a problem with the eyes crossing and things like that. So that is the patient's refractive error. Now, I'm always asked, well, you get to dilate your patients, and many people are told, well, I'll create glaucoma if I dilate the eyes. In some cases you might, but if you do, you're doing the patient a favor. These drops, if you can get the pupil even 1 millimeter, 2 millimeters bigger, you can see so much more inside of the eye. So we routinely dilate everyone. The only one you might be a little cautious about would be a person that's older, that has a cataract, that is farsighted. Orientals have narrow chambers, because what happens if you dilate the eye, there is a potential to create an acute glaucoma. But most glaucomas are the chronic open angle glaucoma, and those can be dilated. We use these medications, Madriacil, which is tropicamide, 1%, and then 2.5% neosynephrine. We a lot of times put proparacaine in because the other two drugs kind of sting, but that's not necessary. But if you just put in 1 drop of Madriacil and open the pupil another millimeter or 2, it's remarkable how much an improved view that you get of the retina. Now, this is the way an acute glaucoma attack presents. And you can see that there's a red eye. Now, in this case, the cornea is a little bit steamy, they call it, or cloudy. These patients are in a lot of pain, and the pupil is mid-dilated, rather as in miotic as in iritis, it's mid-dilated and it won't move. Many times these patients come in vomiting, complaining of a severe headache and that sort of thing, and they don't get to the eye doctor till the next day, when the whole problem was their eye, when they might have thought it was a stomach disorder or something like that. And so the patients are treated with drops to lower the pressure. The normal intraocular pressure in the eye is about 15 millimeters of mercury. In an eye like this, it may go up to 70 millimeters of mercury. And so the prolonged damage on the optic nerve can cause permanent damage, so they need to be treated. And then a few days or the next day, they'll put iridotomies in the eye, or just little holes in the iris to let the fluid flow. But that's very rare if you're cautious, and you can always, if you do dilate the patient, just let them know that this is a potential and to report to the emergency room or the eye doctor when this should happen. Now, this is what you see when you look into the normal retina. This is what you would hope to see. The annular ring there, this light is the optic nerve, the veins and arteries coming out of there, the central retinal artery, central artery vein. The darker spot there is the macula. That should look good and healthy, and you should see a little bright reflex in there. There's a little concavity in there called the fovea. When light hits that, it reflects back to you, and you want to see that. The kind of orangish thing that flares out, that's the nerve fiber layer. So this is a healthy looking fundus or retina. Now this is what happens in hypertension in your older patients. You see that the vein there is beating, it's backing up. The vein crosses the artery there and creates a right angle, and that's called nicking. You can see the cholesterol in the blood vessel, so it'll give a copper wire or silver appearance when you look in there. You often see hemorrhages, you see exudates, you see cotton wool spots, which are indication of ischemia. In most cases, the patients already know they're hypertensive, and so we usually don't catch too many hypertensive patients, especially in modern medicine in the United States.
I thought when you saw the little cotton wool spots that that's also a sign of HIV.
Well, it can be. That's ischemia, and you'll also see it in diabetes. So you'll see it in many cases. Anytime you see those cotton wool spots, that's correct. Now, this patient has had a sudden painless loss of vision. You don't really see much there. The blood vessels are kind of faint. It looks a little bit opaque. You do see the fovea there in the middle, but there's no blood there. Unfortunately, the patient won't have much vision. They'll lose their vision when this happens. It's rare, but when you have a complete central retinal artery occlusion, there's not much you can do for them. Now, this is just the opposite. It's just full of blood, and this is the vein has blocked up. And these are much more common. This happened to be a central vein occlusion, but more often they happen in the different quadrants. And these are not an emergency. They'll resolve over time, and even the disc edema there will resolve over time. There is a potential later on of them getting neovascular glaucoma, so they need to be referred, but the ophthalmologist will just watch them and monitor their pressure over time. Now I want to switch a little bit into neuro-ophthalmology. Again, we're pulling out our pen light. Okay, and in the patient, when you look at pupils, again, I want you to judge their size, and when you shine a light into one eye, the other eye should constrict. So we call it the swinging flashlight test. You flip back and forth. So when you flip to the eye, it should constrict. If it dilates, you have an afferent pupillary defect, or you have optic nerve disease. If you shine the light into it and it dilates, that's an important sign, and that needs to be referred. Now you can also check ocular motility. So if you have a patient there, look at your pen light, you'll see the pupillary reflex right in the center of the cornea, and they should be symmetric. If a patient has a strabismus or non-binocular, walleye, cross-eye, they'll be displaced. Many of those are long-standing. Many of them can be associated, acquired with third nerve palsy, sixth nerve palsies, and diabetes and different conditions. So the way you check for a strabismus is you hold the pen light there, and then you move your fingers across there. First you cover this and you watch for movement in the other eye. If you see movement, they have a strabismus. Some of the angles of strabismus are so small that you just can't pick it up, but if you move that and you see a movement, then they have a strabismus. A lot of situations stop there. Many of your patients have more eye strain and that sort of thing from what's called aphoria. So to measure that, you have them still look at the pen light, but you crisscross back and forth. And if you have that, you'll see big movements in here. So these patients are binocular, but to hold their binocular, they really have to strain to pull this in, and then intermittently they'll get double vision or this sort of thing. And so that's aphoria. And so you can test for that, and if you see a large movement, there are different things that we can use to compensate for that, including prism or different optical devices. Now, color vision is important to test also. So you get these little pseudo-isochromatic plates, and you just ask the patient what number they see. Almost every time that I see it in a clinic, patients are tested with both eyes open. Now sometimes that's necessary because they're coming in for a physical to see if they're applicant for a certain type of job, maybe electronics or a pilot or a fireman or something like that. They have to have that. But get in the habit of measuring each eye separately. They should see all of the plates and read them correctly. In optic nerve disease, you lose color vision. Now this is papillitis, or optic nerve inflammation. Now this one just happens to be at the optic nerve head. Most of the time they're farther back in the nerve. So this is the condition where the doctor sees nothing, but also the patient sees nothing. And the leading cause of retrobulbar optic neuritis is multiple sclerosis. So we need to monitor these patients. Now on the other hand, this is papilledema, and if you can appreciate it, even though that's a flat screen, if you look at the blood vessels, they're elevated. They go up over the elevation there if you track them, and so this is caused by intracranial pressure. And so sometimes this can be a mass in the brain and tumor or whatever. So these need to be evaluated. These patients may have diminished vision, but they usually see pretty well. In most of these cases, you do see that afferent pupillary defect. They do have color vision deficiencies. Many of them will also have little hemorrhages around where that part of the optic nerve is edematous. Now this retina looks pretty normal, except look how pale the optic nerve is. This is a blind eye, even though it looks very healthy, except for the paleness, and that the optic nerve is just atrophic. But otherwise looks very healthy. You see the retina looks very healthy, and unfortunately the eye is blind. Now this is supposed to represent a tumor in the eye. This would be pretty obvious. It would be hard to miss this. Tumors in the eyes of malignant melanomas occur less than 0.05%, but they are there, and that's why if you dilate the eye, we would rather have you do that than take a chance with acute glaucoma and pick up something like this that might be life-saving. This is what a retinal detachment looks like when you look in there. And you see the grayish part on the top there, that's the retina. And so it has just come loose. And in this case, it hasn't gone too far, but if it comes down and affects the macula or macula off, it does affect vision. And the chances of them getting good vision after it's reattached are not as good. So again, this is an important time to dilate the pupil and look. These patients complain of flashes and floaters, and sometimes even a positive scotoma, which means a black area in their vision where they can't see that. So they need to be referred. If you catch it early, they're now lasered, which they're just scarred up and they hold fine. Now this particular one will have to have an encircling band around the eye to cause a spot, they call it a space-occupying lesion, and then the retina will fill over over that and reattach, and hopefully vision will be good. But remember, it's flashing lights that don't go away, and floaters. We all have these little floaters that float in front. We see those periodically, but these don't go away. But also right around 60 to 65, most vitruses detach. And the vitreous is that gel between the lens and the retina. As we get older, it becomes more liquefied and it collapses on itself. And so as it collapses, you see that floater, and they'll complain about that. But even so, you don't assume that that's just a vitreous detachment. It's best to refer and make sure it's not a retinal detachment.
If you had a retinal detachment and then you reattached it and you had double vision after that reattachment, is that because of scarring? What is that?
That's because they have altered the interocular muscles when they put that band around there. Or they have, when they do that, when it's cinched down, it makes the patient myopic, or it changes it, makes the eye longer, and it creates a difference between the two eyes. So it's fairly common. Sometimes it resolves, sometimes we have to use glasses, sometimes contact lenses to do that, but that's because of the surgery itself.
How frequently do you see retinal detachments after cataract removal?
Nowadays, it's not as common as it used to be, very common.
Well, I had two uncles that both,
Is that right?
in fact, one was blind in one eye after the retinal reattachment because it didn't work, and then they waited a long time before they ever did the second cataract surgery, but then it also detached, but they were able to attach it, so he had pretty good vision. And another one had his detached, and now he's got the double vision.
Does he?
I guess because of the band that they put on.
Yeah, so that's exactly what happens. Nowadays, when they leave the capsule in there and they just put in the interocular lenses, you see far less of that, although you still do see complications from the cataract surgery. Exactly right.
Does it? It's not because it runs in families or anything?
Yes, it
can run
it
in
sure
families?
can. It very much can. So if you have a family history of retinal detachment, absolutely. That's one of the first questions we ask.
You don't frequently see retinal detachments that just because somebody's out straining or exercising or things like that. I mean, can that cause it?
Absolutely.
Absolutely.
Yeah. And vitreous detachments are very common with joggers, retinal detachments, and also because that movement will do that. And usually they're just spontaneous detachments, but they're more prevalent in highly myopic patients.
I
Now,
have a question about the detached retina
yes, sir.
from El Paso. You mentioned about the floaters. Are they common? And you know, because every so often I see little black spots moving in front of my eyes, and then they disappear.
Yes, that's a very good question. And most people do see those little floaters. Those are little cellular debris that are in the vitreous. And you see them particularly if you look at an image, like the sky or a wall that doesn't have pictures on it or something. And what happens is that those little floaters get in the visual axis, and when light comes into the eye, you see the shadow of the retina. You see the shadow projected on the retina, and that's why you can't catch it. But a few of those are very common. Now, if those were always there and also associated with the flashing light, then I would be concerned. But what you have are vitreous floaters and nothing to be concerned about. Now, if we go to the next slide. Now, this is a characteristic that's seen in retinitis pigmentosa. They call those bone spicules, and you don't have to go very far out with your ophthalmoscope to see these. But these patients have damaged rods, photoreceptors, and so they are blind at night. Some people don't know they have it, and so someone is always leading them around to the car at night or in the theater to their seat, this sort of thing. It's a genetic disease. It's classic for this. Now, eventually they'll go blind because it will involve the cones as well. But, and unfortunately, there's nothing that can be done about it at this time. But this is a very classic presentation of retinitis pigmentosa, RP.
And what did you call those other things?
Bone spicules.
Bones?
Yeah, and they're very dark, and they're just very, you can't miss them if you see it. Now, I want to be a little more specific about the macula. The macula is the area of the retina that has the most nerves and our good vision. This is a little tear-off sheet that we give patients that we think might develop macular degeneration or already have it. And all it is a checkerboard. And we ask the patient to put this up on their bathroom mirror or refrigerator. And this has to be done with one eye at a time. So they block one eye and look at this either through their bifocals or however there is, at a little black dot right in the center. And all of the squares should appear the same size. If they start to see a change in that, or part of them missing or part of them shifting, they are to call us immediately because they need to be seen, because there's probably some type of fluid loss in there or whatever that needs to be treated. The macular degeneration is changing. So these are called Amsler grids. Now, some patients will report to you that when they're reading the newspaper, the same thing happens, because again, it's a line and they'll miss part of the letters or it'll bow up and down. That means that the macula is involved. And the macula is so important because if we just get just a small area off of the macula, we don't see very well. And to demonstrate this, this is a eclipse burn. This patient looked at an eclipse and burn the macula. So you see that little dot there, which is not very big, but this vision is now only correctable to 20/60. So you get farther out and our vision's 2400 or worse. So if you lose that central vision of the macula, it's very important.
If you were a welder, could you have this type of burn?
The welder usually burns the cornea.
The cornea.
Yeah. Now this slide, these are, sometimes you'll look into the macula and you see these little white spots. These are drusen, or little changes in the retinal pigment epithelium layer of the retina. These patients have a tendency to get macular degeneration. So they need to be photographed and monitored and maybe given an Amsler grid. But you see them especially in the macula, but they can also be in the peripheral retina. Now this is a patient with macular degeneration. And it's one of the most frightening diseases that you tell your older patients, because they know people that have lost their independence because of macular degeneration. You never go blind from macular degeneration, but you lose that central vision, so you can no longer drive. You're dependent on someone to take care of you. And to date, there has not been a whole lot that you can do about it. There is some new therapy. One of them is very interesting. They relocate the macula. So operating inside the eye, the surgeon shifts the retina to a part that's healthier. I've seen one patient here that had 2400 vision, or essentially not usable vision at all, had the surgery and had 20/40 vision. He was referred to me because he now had double vision, because now the eyes were not lined up, but we were able to compensate for that with prism, and this was like an 80-year-old man that now had vision back, could drive. So it's very important. The newest thing that they're doing is called photodynamic therapy, where they inject a light-sensitive dye into the arm. It travels up through the bloodstream through the eye, and then it is lasered. The chemical or the drug only goes to the area that has the neovascularization net, or the little net that they call it, and the laser destroys that. Usually the vision doesn't improve, but it usually doesn't get worse. But this is just kind of Star Wars stuff that is just starting to come about there.
Well, with your macular degeneration,
Is it operative from the time it starts until whenever, or does your eye reach a point where surgery is no longer?
There may be a point like that may not help, but in some of those cases, it's maybe worth a try. That's worth a shot. Now, also remember that we also have what we call low vision, and many of these patients can benefit from, we'll give them TVs about the size of this, where they can magnify print, they can write checks out. There's a lawyer in town that's a very famous lawyer who's a patient of ours. That's the way he does everything. And he has macular degeneration and does quite well with low vision aids. So keep that in mind. So you just don't give up on macular degeneration patients.
Excuse me, did you say they do not lose their vision completely?
That's correct. You can reassure them or give them a little bit of reassurance because they'll always have their peripheral vision, and that makes them feel a little bit better. But that central vision is so blurred that they do lose their independence. Now with the next slide, this describes glaucoma a little bit. We used to just routinely measure the intraocular pressure, which we would hope it would be between 15 and 20 or so. And if it was, not worry about it, even though they may have an optic nerve that looked a little suspicious. Nowadays, the thinking is just the opposite. And so we measure what's called the cup to disc ratio. So we measure the size of that little wide area to the size of the rest of the optic nerve. In this case, they're calling it about 0.2. In other words, that's about 20% of the optic nerve. The average is about 2, 3, 4, somewhere in like that. This patient, we would hope, would have a 0.2 and pressures of 15, 16. Now this patient, what would you say, 0.8, 0.9? So it's fairly cupped out, it's very pushed out there. And so this patient may have pressures of 15, but an optic nerve like this, and the patient has glaucoma. So even though a patient has normal pressures, they can still have glaucoma. So if you see an optic nerve that looks like this, they need to be referred for visual fields testing. And these are real easy to see when you look in the ophthalmoscope. So normal should be about 2.2, 0.3, and if you see something that's 5, 6, or if you see an asymmetric, if one eye is different from the other, refer the patient for an evaluation because you'll be doing a big favor. There are a multitude of drugs now that can stop the progression of blindness in glaucoma patients. Now, let's get to...
Excuse me, I have a question on the glaucoma. Is there an increase of glaucoma and diabetes?
That's correct, there is. I don't know the exact amount, but glaucoma and cataracts are more prevalent in diabetic patients. And that's a good lead into this next slide. This is diabetic retinopathy. And in Texas, we see a lot of diabetes. This first slide shows, if I can magnify it a little bit, you can see some little blot hemorrhages. They call them blot and dot hemorrhages. You see little hard exudates there. This is again where you can see those cotton wool or ischemia patches as you see in your AIDS patients. But this is further divided into mild and moderate and severe depending on how many quadrants are affected. And in the United States, the leading cause of blindness between people of 25 to 74 is diabetic retinopathy. So in San Antonio and the rest of Texas, where we have such high diabetes, it's very important for diabetics to have a routine eye examination, a minimum of once a year. Now, even in a non-proliferative, or what was formerly called a background diabetic retinopathy, you can still have clinically significant macular edema. And that's when the macula becomes edematous, and that can be treated with laser and save these vision. So even though a patient just may have a dot or two of hemorrhages, don't just assume that their vision is okay. They need to be sent for fluorescein angiography and an evaluation and possible therapy with a laser for that. Now this is the optic nerve, and this is proliferative diabetic retinopathy. So this diabetic retinopathy is more serious. And you see all of those new blood vessels around there, those are neovascularization. And what happens in diabetes is that these break, they bleed into the vitreous changes, it causes traction and detaches the retina. So this is neovascularization of the disc. You can also have this neovascularization elsewhere, NVE they call it, which is in the peripheral quadrants of the eye. I'm sorry, I went the wrong way. Now, this eye has been treated for diabetic retinopathy. This is pan-retinal photocoagulation with a laser. and it's been the greatest thing in the world for diabetics because it has saved their vision. And the surgeon will apply these little laser spots, about 300 at a time, up to about, and they'll make about 2,000, and they'll completely block out all of the peripheral retina there, and it destroys the neovascularization. And surprisingly, the patients don't complain about visual field loss, but it keeps their diabetic retinopathy from advancing, and it saves their vision. So this is a nice one. Now, this was fairly fresh because it'll scar later, and you'll see more black spots, and you'll see the white ones, but it's a nice picture. And you can see how accurate that laser is, so they miss the blood vessels, and they just pinpoint it right along there, and they do that with a special lamp and a laser. Well, that concludes my presentation, so.
Well, let me ask you a question.
Because we're in the long-term care field, most of us are, does Medicare or Medicaid pay for any of these procedures for diabetics or people who have?
Sure.
It
Yeah,
does?
yeah. Yeah, they should all be referred. And if a patient can't be referred, we have the University Health System that can help these patients, and they should be referred.
I also have a question. I want to just check in detached retina, do they have pain?
Surprisingly, not very much pain. They may initially, but it's not very much pain involved. Okay. Thank you.
What goes up must come down. Spinning wheel got to go round. Talking about your troubles, it's a crying sin. Catch a painted pony, let the spinning wheel